Okay. We're going to complete the chapter that we started last night. We're going to do burns. Burns are a whole topic for itself. And after that, we'll move on to whatever else was scheduled for tonight. Burns. Okay, in EMS, we do see a lot of burns. Okay, it's very common. People get burned. Well, when we speak now, we're speaking about generalized burns. We're not really going to specify how the burn occurred. That we'll get to a little bit later, because there are some slight differences. But in general, we talk about what's known as thermal burns. These are burns that occurred from a heat source, all right? It doesn't matter if somebody poured hot chicken soup over their hand, or they touched the element of an electric heater oven thing, or they got steam, in their face, or some other, doesn't matter. It's all very much similar, it's all considered burns. So the first thing I'm going to teach you is how we classify burns. And every EMT needs to be able to understand the differences between these three classifications of burns. And it's not difficult. Okay? Burn number one is known as a superficial burn. You do need to know both ways of describing it. It's called a superficial burn, and the simple day-to-day way we describe it is a first-degree burn. You need to know both words. Superficial burn or a first-degree burn. How would I describe this? Very simply. You went outside without putting on any sunscreen, if you have a complexion such as mine, and you went out into the boiling heat of the sun, you walked around, and you got red on any exposed part of your body. That redness, that sunburn, if you like, the redness, that is the characteristic of a first-degree burn. Again, it doesn't matter how they got it. They could have spilled hot coffee over their back, their lap, their legs. It doesn't matter how the burn occurred. You come there, somebody shows you a body part, and it is red, and you can assume or deduce that there was a source of heat that caused this redness, that's a first-degree burn. All right? So you must understand this.
Red pigment.
Red, not pigment, a redness of the skin. Okay? Pigment would imply that a color had been applied to it. So I don't like the word. The skin has turned red. All right? From some sort of heat source. All right? That is a first-degree burn. That is known as a superficial burn. And that is an extremely painful burn. Okay? So, as you get older, you get a little wiser. Right? You realize that, even though you're wearing a baseball cap and you're walking around, in the Dead Sea area, but your ears and your neck is not covered by your baseball cap, all right? So you have to put on the sunscreen. You have to understand, right? Short sleeve shirt, okay, that's great. You gotta sunscreen up the parts that are exposed. So that's your first-degree burn. Again, it has nothing to do with a sunburn. I'm just giving you the number one way to remember. So if you're reading in a text or in an exam or whatever, and they're talking about redness to the skin, redness from a burn, doesn't matter how they got it. The skin is red. How are we classifying the burn? First degree. That's simple. Superficial burn. Number two is known as a partial thickness burn. Partial. Partial means not all the way, just part. And we call it, day-to-day medicine, we call it a second-degree burn. Second-degree burn. What is the difference? How do I differentiate between a first and a second-degree burn? And the answer is the presence of blisters. Once the skin blisters up, and you see these white It doesn't matter what size. Could be very small, could be huge blisters, could be they popped, could be the patient popped them. All this doesn't matter. The fact is there is redness, and there are these blisters, which are typically white, second-degree burn. This is a more serious burn. This is going to be okay. We got first degree, we got second degree. Partial thickness. Again, extremely painful for the patient, and we'll talk about how we're going to treat it, what we're going to do for these patients. Okay. Third burn is called a full thickness burn. All right, superficial, partial thickness, full thickness burn. A full thickness burn that we call, again, easy to remember, third degree burn. This is where the skin, the flesh has burned, and if you look here in the picture, you see all the layers, all the way down to muscle, sometimes including the muscle, has burned. Nerve endings have burned. This is the most serious type of burn that we're going to talk about in EMT class, and you will see either black or white charred. You've seen white if you ever use coals on a barbecue, and after they've been there for a certain amount of time, they turn white. Okay? That's the same concept. The skin will be completely burned. Now, well, this is white from a burn, not white from a blister. It's burned all the way down. You can sometimes see bone. Okay? It'll look black, like a piece of steak that's been left on the grill way too long. Okay? I don't just mean way too long, it's been overcooked. I'm talking about charred. Right? You leave a piece of meat on the grill and just let it stay there, it's going to turn black and crusty. That's a third degree burn. I just want to address this because I don't like it. So I'm going to address it. And it says it in every textbook, and it's a big mistake. So I want to clarify it and make sure you understand. There's no such thing as a third degree burn without second and first accompanying it. Every burn always has the ones below it. Okay? The only way you could get a third degree would be like to take like a cattle prod thing with a boiling hot lead end and just touch straight down into somebody's skin and remove it. Yeah, there you may get a third degree only burn, but typically your thermal burns that you're going to see in the field are going to be accompanied by second and first degree burns.
So they get worse?
So,
close to it, adjacent to it.
it'll actually be more like a bullseye situation. Okay, around it. Now, this is why I want to address this, okay? Every textbook you read is going to tell you that third degree burns are not painful. That is not true, okay? First and second degree burns are extremely painful. The point where they have third degree burns, they may not feel any pain there. You understand what I'm saying?
Is that because all the nerves are
Because
gone?
the nerves have been burned and there's no feeling being transmitted. But right around it, they're going to be in tremendous amount of pain. So I just don't like that you'll see this, and if it doesn't get explained, you'll just walk around thinking, oh, third degree burn, yeah, they're fine, they're hunky-dory, right? They're sitting there, you know, playing the piano or something. No. If they've got a third degree burn, they will be in extreme pain from the first and second degree burns that are surrounding it. Third degree burns you're not seeing every day. Okay? I will say, I don't do well with medical statistics because I don't care enough to, but I would say from my practice, 90% of burns are first and second degree burns. Okay, that is what you will see on all the burn calls that you go to, okay? Third degree is rare, right? And you can see why, right? First degree is superficial, second degree, okay, it's partial thickness, we're getting through, some of those layers, but to burn all the way down to the muscle, burn all the way down, sometimes burn the muscle and see bone, that's not happening every day, all right? But again, you must be prepared for all three. You have to be able to classify what burn you're bringing in.
Does partial thickness penetrate the skin, or just blisters?
Yes. Yes. Here's a picture of your
Yeah,
skin.
you
Here,
mentioned
your
it.
3 layers of the skin.
You mentioned the blisters, I wasn't sure. So
Yes,
blisters,
here.
and it could be.
Yeah.
So full thickness is the amount of seam.
Right, all the way down. Okay. So this is a picture, you can't really see it because the lights are on, but this is huge blister. You see this blistering?
That's a torso? Ooh.
Yeah.
What up?
Okay, you see that?
That used to be black or white?
I get black. Alright? Lights. Thank you. So, thermal sources of thermal burns could be any of these things that you see here. Whether it's fire, whether it's radiated heat, steam, hot water. These are all thermal burns. They all do the same thing. They all cause similar damage. Electrical burns we're going to speak about. A little bit different. And chemical burns we'll talk about also. They're slightly different.
And friction burns? What are they categorized?
They're just like thermal burns. They're just going to be the same. They're most of the time just going to be first degree. Okay? Alright, so I want to draw something on the board. I want to... Okay, so we're going to learn the rule of nines. Okay, this is something that every EMT needs to be familiar with. I just don't like the way they teach it in the textbooks. Okay? So, the rule of nines, I'm going to teach you my way of doing it. I'm going to show you what you should draw on the back of every test sheet that you get. Remember I said when you get a test sheet you may want to draw and write stuff. This is something that's worth writing. Okay? So I'm going to show you a very simple diagram how to remember the rule of nines. Okay? So we're going to look at the board. You can stay in your seats. We're going to come over here. Alright. So the rule of nines works like this. It's giving you a way to calculate approximately how much body surface area, and this is an official medical abbreviation, BSA, body surface area, has been affected by the burn. Okay? Because if you come into a hospital, they're going to want to hear from you, what is your estimation of how much of the body has been burned? Okay? So, this is what I advise you to do. Okay? You draw a stick figure such as this chap here. Okay? You can give him a face if you want. He's not happy because he's been burned. Okay? The rule of nines, okay, this is as difficult as the mathematics is going to get in EMT school. Okay? If you go to medic school, yes, you're going to have to really have your math up there, okay, to be able to do dosing calculations for medications. This is as far as the math is going to go. Basically, what math would say is that 9 multiplied by 11 equals, look at that, we got mathematical genii here, right? So this is a rule, this is a true rule. Okay, 9 multiplied by 11 equals 99. Which means, very simply, that there are 11 regions in the body that I can assign 9% to. Okay, and once I've assigned all 9% to my 11 regions, I have reached 99% of the body, and the 1% we'll get to in a minute. So here we go. This is what I suggest you draw. I would not do the face necessarily. Yes, question?
No, I think the hand was 1%, right?
No. Alright, here we go. So, the head, this is for an adult. This is for an adult patient. Okay? Adult. Okay?
Why are you breaking it up by 11 though?
Because I need to get to 100% of the body. And it's called the rule of nines.
Oh, okay.
So there are 11.
No, but close.
No, but-
11 is between 11, no, 11
How many different regions are there?
11.
Oh, there are
11.
11 regions,
I'm
okay.
going to show you.
Oh.
Ready? Here we go. The whole head, front and back, is worth 9%. Each arm, front and back, circumferential. That's a word we use in burns. Circumferential. That means all the way around is worth
9%.
9%. So now we've got 3 of our 11, right? The abdomen. No, let's start with the thorax. The thorax, front or posterior, and the thorax anterior are each worth 9%. So this is from the neck and down all the way until the diaphragm. 9 posterior and 9 anterior. Great. Now we have the abdomen. Abdomen. Anterior abdomen is worth 9. Posterior abdomen, which means back and buttocks, are also worth 9. How many have we got so far? 7. We're getting there. Each leg
9.
has an anterior and a posterior portion. Okay? So you will have 9 anterior, 9 posterior for each leg.
Oh, it'd be 4.5. Oh,
Okay? So, how many 9s do I have?
11.
I have 11 9s. So I've covered the entire body. Now, how do we use this in real life? Okay? How do we use this in real life? The way we use it in real life is that it's very rare that a patient's entire leg will be burned, right? Very often it may be from pelvis to knee. So if I know that the entire anterior portion is 9%, then half of the leg will be 4.5. And so on and so forth. If the entire arm is 9%, that means anterior, posterior, all the way around, and they only burn from their elbow to their wrist, well, that's a quarter of the 9, okay? This is something you have to work out. On state exams, you will only be tested in round numbers, whole 9 categories, okay? It will give you body parts that got burned, and the answer must be a multiple of 9, all right? So if you're writing, 32 and a half, you made a mistake, all right? It's gotta be in the 9 times table. So that's a clue.
could be 9 and 4.5.
On a state
Or it
exam,
won't be 4.5?
it won't be. It will only be whole 9s. So, I hear you asking, how do we get to 100%? Because there we're only showing 99%.
Shut up. Video.
So the 1% is the genitalia, okay, the bris area.
Speak for yourself.
Now, when I speak to class of African American students, I have to say, brothers, I understand. It's not true, but we have to accommodate even the Asians, okay? So we have to make, a
Round.
right. We take a median sort of number that accommodates everybody, and that's called the 1%. In medicine, that area is known as the 1%. A person's 1%. It's just a way, a sort of a more adult way of saying that area. Okay, it's commonly used. The pediatric rule of nines you do not need to know for EMT school. And I find personally this one extremely complex to understand. So I have all of it there. That's something you can reproduce quickly on your paper. And whatever they throw at you, you calculate. All right? Okay, as well as understanding how much of the body has been burned, we also have to remember that there are 5 locations that will up the severity of the burn and make it into a critical burn, just based on where they are in the body. Those 5 locations are listed here: hands, face, feet, and genitalia. Was that 4? Yeah. Hands, face, feet, and genitalia. These 4 locations automatically bump the patient up to critical status.
Why more than the thorax?
Why feet and feet?
This is the rule.
If what happens?
Okay, patient got burned, right? And we need to now assess the amount of BSA, body surface area, that was burned. After that, we have to decide, is this a critical burn? The reason we need to know that is because we have to, especially in New York City, we have to decide, can we go to a regular hospital or do we need to go to a burn center? Only critical burns go to a burn center. So what I'm telling you is that hands, face, feet, and genitals automatically get bumped up to critical status.
No matter the.
No matter the amount or the size of the burn.
It's all together or either one?
Any one of these 4 places.
So the guy burns his hand, he's going to a burn center.
Yes. Whereby if he has a much larger burn and it's on his arm or his leg, may not be necessary.
Does it make a
Okay.
difference if it's first, second, or third degree?
Not really. First degree, we generally don't take that seriously. So when we're talking about critical, I'll show you in a minute, I'll show you some numbers, all right? Again, you know, there's different textbooks, different things. New York City says over 60 and under 5, those are critical burns also. Okay, New York City.
New York State is 55.
All right, so what?
New York
The
State
patient.
55?
Yeah, 50, 55.
For the test, what are we gonna say?
They won't ask you that. Alright, so this is basically a chart. I don't like to get into too much reading on charts and things like that, especially if I didn't make it. But what I would emphasize are things like this. In order for a first degree burn to be considered critical, you need it on 75% of your body. That means that you went out in a Speedo, okay, and you lay down on the beach somewhere in the Mediterranean, okay, and just waited for it to happen, okay? And then,
And you turned over in the middle.
oh yeah, you had to turn over, sure, okay? And yeah, you can get over, yeah, so you'll definitely get over a 75%. If you do that, that's a critical burn. So you understand if someone gets a first degree burn on their arm, right, we're nowhere near 75%. This is not a critical burn.
Okay, the burn go from first degree to second degree on its own, without being in the sun, let's say.
Well,
Overnight.
it's not really on its own.
Burn.
Burns will sometimes, if untreated,
Right.
progress. Yeah. Okay? A second degree burn, to be critical, we're looking at greater than 30%, except in these 4 locations, hands, feet, and genitalia, then they get bumped up right away.
What percentage?
So it's either or.
1% on the hand? It's critical?
Second degree anywhere, hands, face, feet, genitalia, if there's second degree, it's critical burn.
Oh, that was 27.
So it's either or, not both.
Or 30% in other parts of the body. Okay? And that we do see.
So, I mean, technically a blister on a finger would fall into that
That would
category.
fall into hand, yeah.
Right.
Okay, again, I can't
Use
answer
your judgment,
the question, what would I do, you know, in certain circumstances, we're not getting into that. I want you to just have a general overview that we're looking for amount of body surface area that has been affected. We also want to know, is it a critical burn? Okay? Third degree burn is anything greater than 10% of the body anywhere. Okay, is critical burn. And again, anything to these four locations: hands, feet, and genitalia. Anywhere, okay? Again, first and second, if there's a burn in the respiratory tract, and we'll probably talk about that a little bit later tonight, that's automatically a critical burn.
Inside?
Yeah. Yeah. You only know that they've burned inside because you will see if they have any facial hair or even a nose hair or so that's singed. And
So they swallow chemicals?
no, usually it's from like some sort of the one case that I remember clearly was a guy trying to fix an air conditioning system in a very large public place at a time when there were thousands and thousands of people in there, and he was cleaning the wires with some sort of metal brush and somehow shorted and it exploded in his face. And there was an electrical,
And he inhaled.
yeah, and he inhaled. You can't not, you're going to inhale. So that would be, you know, we'll talk about that again in a little bit.
Why does the first degree burn not say circumferential burn in the critical block?
Because it doesn't matter, I guess.
Again, if it's less than 75%, it won't make it critical. Circumferential burns are critical if they're second degree. That means that they go all the way around any particular limb or body part. Okay? So how do we treat burns? Right? That's our job. We need to treat burns. So the first thing is always the same rule: stop the burning process. If somebody touches something or spills boiling water or chicken soup over them, and now the chicken soup is not being poured on them, the burning process is still continuing. Okay? Just because they took their hand away from the
Element.
source, it doesn't mean the burning has stopped. Just the opposite. The burning is continuing. Okay? Through the skin. So, your job is stop the burning process. That is your job. Okay? I can say, in all honesty, that I have seen the craziest home remedies for treating burns. I don't even have time to list all of them or even some of them. I mean, crazy, crazy stuff that you would not even believe. Okay? I can't make this stuff up. As far as you're concerned, as EMTs, the only treatment for a burn is cold running water. Let me repeat that. Okay? Cold running water. Don't ask me, I heard, or I thought, or my grandmother said, or I did. No.
So no
No, I don't want to hear him. I don't want to hear him. Again, should I say it a third time? The only treatment for a first, second degree burn, as far as you're concerned, is cold running water.
How cold?
Okay? Just whatever comes out of the faucet or the shower. Okay, we'll get to this in a minute. Sometimes the burn is so severe.
How do you do that while transporting?
Slowly. You're in the house right now. You didn't transport yet. Sometimes the burn is so severe that jewelry, watches, clothing actually adheres to the skin. Do not try to pull it off. Okay? Because you will schlep off skin with it. And we don't want to make things worse. You can cut away at loose clothing, but you do not. But you do not pull at clothing or jewelry. Okay? Next. You need to cut away and expose the burn portion of the body, okay? You can't leave the pants and they tell you, yeah, my leg is really painful because I spilled, this great big Shabbos urn of boiling water on there, and you're like, oh, I don't want to take the pants off or whatever. No, it doesn't work like that, okay? You need to expose, and if it's a large area, they need to be in the shower, okay? Again, not a bath, not ice, cold, running water, okay? Let the water run over the burn. Okay, this is something that you
For
have
how
to
long?
understand.
How long?
It's just 15-20 minutes.
As long as you can. As long as you can, till you're ready to make the transport, till you stop the burning process. If it takes you 20 minutes, then better to wait on scene the 20 minutes, at least give them some sort of comfort. You asked, how do we do this en route? So there's two methods. One method is to wrap the burned area in moist, sterile dressing. Okay, so you'll have these large burn sheets, which you will moisten with sterile water that you're carrying in your trucks, and you will wrap the burn in these burn sheets, and that will keep it moist, at least wet, will give them some pain relief. Obviously, you should call for medics to provide analgesia, to provide real pain relief, because burns are extremely painful. Okay, I mean, Baruch Hashem, I haven't really suffered except for that time in Israel when I, thought I was doing good with the baseball cap and I wasn't.
Oh, I thought we didn't have coffee.
Yeah, I couldn't find coffee, right. So, they're painful. They're really painful. And, you get a lady on Friday afternoon, she's cooking, she's multitasking, million things going on. And she touches the top of the oven, she's pulling something in. It's painful, okay? And they'll blister up pretty quick, you'll see it. So moist dressings. Let me talk about moist dressings for a minute. I'm gonna link burns to shock, okay?
Can I just ask a quick question?
Let me just finish my thought, and then yes. I'm gonna link burns to shock for a minute. If a large percentage of body surface area is burned, patients will lose which part of the 4 blood components?
Capillaries.
No.
If
What?
what?
Capillaries don't make blood.
What do you say? What?
Patient gets burned on a large body surface area, large part of their body. Which part of blood is getting burned? Are they losing?
Plasma.
Plasma. Right? If a patient loses a lot of plasma, which type of shock are they going to go into?
Hemogenic?
Hemorrhagic, hypovolemic. You sort of said both,
I said them
you
both.
combined
It's
them.
actually the password's your YouTube account. Now you gotta learn how to spell it.
Forget it.
All right. So a patient can easily go into shock secondary to a burn. And this is something that they may ask you on a test. Which type of shock?
You can also go into psychogenic, they can faint from the side of it, eventually.
Unlikely that's and again, psychogenic isn't something that's really scary to us. That's self-limiting, that's gonna fix itself. We're talking about shock that's a problem, that needs to be fixed. So just keep that in mind. Large surface area burns could lead a patient into hypovolemic shock. Alright? And if the patient is in shock, then you've got to remember all the treatments for shock as well as all the treatments for the burn. One of the treatments for shock is keep them warm.
Uh-oh. That's a contraindicator.
No, it's not contraindicated. That may be what you've got to do. you may have to keep them warm. Now,
Warm and
here's
moist
the
at the
problem.
same time?
So here's right. So here's the problem. Here's the conundrum that you're faced with. You have a patient with 20-30% burns. We're scared they may go into shock. We've put them in the shower. We've watered them down for 20 minutes. Now we got to go to the hospital, right? How do we wrap them? So there's a rule that if a burn is 10% or less, I personally use 9 because it's so much easier. But the official rule is 10% or less. Then you can wrap them in moist, wet dressings. Because 10% won't cause the shock, the shivering, If they have greater than 10%, you're going to wrap them actually in dry dressings. So you get them all watered 20 minutes, whatever, in the house. Now you get them dry, and you wrap them in sterile dressings. Why are we wrapping them? What is the purpose?
Doesn't get infected?
Purpose is so it doesn't get infected. Burns get infected. Burns get infected, and good burn care will prevent any infection. Okay? Many years ago, everybody that got burned used to get antibiotics. Prophylactic antibiotics, just in case. Today this is seen as very bad medicine. Alright? It's one of the things that was brought up in South Africa as it happens. Today this is not considered good medicine. Okay? Patients should be in a sterile environment. Patients should be really watched carefully in a proper burn center. And use of antibiotics has really been discouraged. And again, even here in New York, last couple burns I took in, I asked, because I like to see where the hospitals are up to in progress and being with the times. And yeah, the last couple hospitals I came to said, no antibiotics. So it's very good to hear that they're...
Even in the hospital they don't give them?
Yeah, in the hospital, yeah.
Unless there's.
Unless there's infection.
Oh, you say even for preventive they don't do it?
Right. Not done anymore. Used to be for everybody. Everybody in the hospital got antibiotics.
And for,
Now-
and just pain control they do?
Yeah, now it's pain control, pain management, yes. That's really important, okay? And again, in the hospital, in your ambulance, keep them sterile. Don't let anything, touch the blisters. Don't break any blisters, as it says here probably, all right? So that's the deal with the 10%, whether it's moist or dry dressings.
This is all for only an adult? That's all I'm asking.
No, it's for everybody.
For a child also, the same care?
Yeah.
They
You
don't
had a
have, like,
question
different-
before?
That's what I was wondering about a child.
Yeah,
And
everybody.
the difference between 30 and 10%.
And same
Everybody.
percentage?
Percentage is the same?
How often, or what would one do if the patient was unconscious and burned?
Okay, so I don't like getting into what ifs because, we'll never move through what we need to do. If a patient is unconscious, then you most probably don't have the luxury or the time to go to a burn center. You will have to go most probably to the closest trauma center. The question is, why are they unconscious? What happened that caused this burn? Was it purely they're unconscious because of the fire? It's more likely, unfortunately, that they'd be in cardiac arrest from the fire and the burning, as unfortunately we saw a number of years ago in Flatbush, than just being unconscious. But again, these are questions and decisions that have to be made on a case-by-case basis. On the way here, we were actually discussing how do I decide where to take a patient. And I explained very simply, it depends on many, many factors. Okay? I'm talking about in a prime, simple case where you have a patient who is stable, who is able to get to a burn center, does not have an airway issue because that's automatically unstable, does not have a blood pressure problem. They're stable. Their vitals are stable, they've been severely burned, or they're over the 30% second degree, or they're on that, the 4 locations that we spoke about. they go to they go to a burn center.
So when do you take the vitals when approaching a conscious patient that's?
Right away.
Before even putting it under cool water?
You first want to stop the brain.
If they're unconscious, you're not putting them under cold water. You're
No.
getting them out, you're going to irrigate them en route.
Right.
It's a whole different story. These are dealing with conscious patients. Again, most of your burn patients will be conscious. Most burn patients will be conscious.
if the
If they're
BSA
not
is,
conscious, they're usually burnt out crisp.
That's what I said. They'll be in cardiac arrest.
if the BSA is greater than 10%, you're gonna cover the whole body. They're gonna cover them something warm over the whole body.
Yeah, you're gonna wrap the burns in sterile dry dressings, and then again, you'll have to assess for shock. That's a whole
Oh,
separate,
so-
right.
You're not gonna automatically.
No. No, only if they're in shock. Alright, special considerations with burns.
What's this thing with New York, go back 1 second, the New York City protocol, you wanna address that?
I spoke about it.
No, that last one.
Yeah, I spoke about it.
Bandage closed burns with a saline moistener?
If it's less than 10%. If it's more than 10%, use dry.
Oh, I didn't realize, okay.
Okay? Now, electrical burns. I just want to speak about electrical burns for a minute. Okay? The biggest problem with an electrical burn is the heart, not the burn. Okay? Let me say that again. The biggest problem, you can take a note on this because it's something you need to know. The biggest problem with an electrical burn is not the burn, it's the heart. Now we haven't touched yet on cardiology, but the heart works on an electrical system. Okay? So if somebody gets an electrical burn, whether they stick a fork into an outlet or whatever craziness they decide to do, we consider the burn, but you really, really need to get these patients transported, and you should get a medic to take a look at the heart. Okay? That's really what you should do for an electrical burn.
Shorts it?
Okay? Yeah, it can cause a problem to the electrical activity and conduction system of the heart.
Even if it's a minimal burn.
Again, the burn size will have nothing to do with it. Electrical burns, typically, there will be an entrance and an exit wound, just like in a gunshot, okay? Because the electricity entered the body and left the body somewhere. So you have to look for those. You have to try to find them on a serious electrical burn. You have to understand also that in Europe, they have like a 240, 220, 240 electric supply in their outlets. We have 110 for the most part, except for the special air conditioned ones that we have that are 240s. So 110, not so bad. But the same, the same thing, if they do the same thing in Europe, one of these European countries, where they have 240, 220, whatever it is, running through their houses, can be a lot worse. So, again, we are concerned with the cardiac electrical system. Chemical burns. So this is something you need to highlight, okay? Chemical burns should be irrigated for 20 minutes. 20 minutes, okay? That's how you have to deal with it. Okay, you wait on scene and you irrigate the area for 20 minutes. You should not be seeing too many chemical burns in the house. What is the exception to that? What chemical do we see in the house that causes...
Ammonia bleach.
Okay, so you have the ammonia bleach thing, but what's more famous before Pesach?
St. Moritz.
Very good.
Yeah.
These oven cleaners. These oven cleaners such as St. Moritz, okay? These cause tremendous burns, okay? Really serious burns. I can't understand why they are legal to sell some of these products. They are seriously dangerous. They're dangerous if you touch them. They're dangerous if someone breathes in the fumes from them. It's not a joke. you gotta glove up, but glove up to the elbows to wear these, to use this stuff. Okay? So, we do see chemical burns. We do see chemical burns, alright? I'll never forget a case. I had a lot of chemical burns, but one case that I remember was a young boy, probably 19, 20 years old, and he was working in a hardware store, and there was a can of paint, the paint that you put on the outside of the old-fashioned white refrigerators. Okay, and in those days, you would sometimes need to touch up and whatever, and one of these cans exploded in his face. Okay, he had tremendous chemical burns to the face and to his eyes. Okay, we saved his eyesight. Literally, we saved his eyesight. Okay, because we acted quickly and we did what we had to do. We irrigated. Okay, and we irrigated all the way in the ambulance. We
How do you
irrigated
irrigate
to
it?
the hospital.
How do you irrigate a chemical burn?
Well, in the store there was water. There was a
You're
sink.
supposed to irrigate it with water?
Yeah. What does irrigate mean?
Yeah, but what if it's...
Water. Always use water. Never ever try, to decide. Okay, now I'm a chemist. Okay, so this was a base. So I'm gonna get an acid and I'm gonna neutralize it. No, don't ever try to do
No, but
that.
can't it be dangerous sometimes?
Water, okay? Just water. Okay? Don't try to neutralize, okay? Don't even try to start making, you're not chemists, all right? Please. Okay?
And this is even though it's the person that's gonna hurt the person, right? Will they be in pain when you do this?
What, the water?
Yeah.
It'll be very soothing.
Absolutely.
Absolutely.
Cold water.
Cold water is soothing on a burn.
The
But a lot-
beginning it
lot of-
hurts, the
a
beginning
lot
it
of-
hurts,
But
and then after.
they get used to
In
it.
a lot of labs, like they have the sprinklers that if you get burned, you
Yeah.
quickly pull it down.
Yeah.
No,
Out of what?
Yeah.
What do you say?
Why? Why they have those?
Right.
For exactly this reason. Why those eye wash stations. Right?
Go right in.
Generally, will chemical burns be first, second, or third degree? Like, or just it also depends on what the...
Depends on the chemical, depends on the amount of exposure.
Gotcha.
It's,
But is that a
I like that.
universal rating system? The degrees? For chemical, electrical, and...
no, it's all the same. First, second, third for all burns.
Just guys, regarding back to electrical burns, you said that it's heart, it's possible for failure of heart.
Yeah.
How do you identify that right away? Meaning,
You'll,
the patient will
the
be,
patient or somebody will tell you.
the patient will be able to tell you that the heart is an issue. with
No, they'll tell you that they were fixing electrical
Right,
thing or they put a fork into the outlet,
Exactly.
right? So now you know there's an electrical burn involved.
Or
But
they
will
struck by
the
lightning.
patient know that
No,
there's an issue with the
no,
heart? Or
not
like
necessarily.
10 minutes later, they'll just collapse.
Not necessarily right. There could be some sort of arrhythmia. That's the word for a problem with the heart conduction system. Arrhythmia. And you'll never
So
know.
any electrical burn, just transport.
Get a medic.
Get a medic.
Get a medic.
Does an
Electrical burn
electrical
should get a
burn
medic.
always have an external wound?
No, not always.
So what is the idea of the entry and?
Yeah, because when there is, there'll be an entry and exit wound.
But
Okay.
not necessarily.
Not
is there
necessarily. It depends. It depends. There are so many
variation?
variations. Like when the air conditioning system blew up in this guy's face, right? That was an electrical burn, but he didn't have entry and exit wound. He had a shot, like an explosion that came at him of boiling air and whatever. His whole beard was singed and his face and eyebrows, everything. Okay? That was an electrical burn. Right? But he didn't have per se an entry and exit wound. Alright, this is talking about exactly that case where somebody inhales some sort of boiling hot air and has what we call a respiratory burn. Here's how you can notice it: eyebrows, facial hair, nose hair, any evidence of burn. Yeah, it's fine. Thank you. You need to call for paramedics for these cases. They may lose their airway really, really quickly, and we need to get there really quickly and take care of the airway. We need to make them unconscious and put a tube in their throat and breathe for them. Okay, because that airway could close at any time. You will not get a warning. They will not be like, oh, I think my airway's gonna close now. It's not gonna happen. So,
You intubate right away.
right away.
You can't intubate a conscious person?
You throw it out.
You do, and that's not.
Or you said make him
No, you
unconscious?
said you.
Can you put this down your throat? Don't answer that question. Burn centers. We're not being recorded, right? Burn centers. Look at this. So, I always talk about Brooklyn because, you know, there is nowhere else really, but we don't have one, okay? Apparently, nor do you, okay? So, Queens isn't on the list.
What's the trauma center?
No, burn center. It's a special type of trauma center. We go now to Cornell. When I started doing this, we used to use Staten Island. Okay? It's based on your proximity. Okay? If you guys can get into Queens and go across the 59th Street Bridge, you can go to Cornell. It's not that far. I don't know how far you are from, like, real Queens. What I call Queens.
Jamaica?
Main Street.
I think restaurants.
Dan Wick or without Dan
15
Wick?
minutes.
See, the man
What do you
knows.
say?
I think restaurants are the,
Food.
their casa here, is
Right.
restaurants.
So,
15-20 minutes.
okay, so you'd go to Cornell. If you live in Borough Park, you're going to Staten Island. Because that's a jump over to Verrazano, right? Over the Guinea Gangplank. Right?
Unless you don't want to pay the toll.
Well, in the ambulances, we don't really pay the toll. If you're up north, you go to Jacoby or Harlem. But Cornell's really good. We always went to Staten Island. Head of Burns in Staten Island was a Jewish guy by the name of Finkelstein. And he was a great guy. He worked with all the Hatzalim guys, and then one day he just woke up dead. So that was the end of that. And a very young guy. Just had a massive MI in the night, and just, that's it. It was done. So we stopped going. We go to Cornell now from Cranhags.
Impartial.
Alright, let's just, I think I've shown you this before. We'll get to it, alright? I think I've shown you this before. I just want to reiterate that you all need to have a watch on skill nights. Okay, you've learned already how to take vital signs, so you understand the importance of being able to measure seconds with a sweeping second hand. Okay, so there was a sale the other week of watches for like $10 or something. I don't know if it was legit, but there are,
I haven't
you
done
know,
it yet. I'll let you all know.
right.
Well, I know money in my bank account left though, but
What?
I know money. I know money in my bank account, but it's nothing to do with that. I'm sure.
Right. Vital signs, we've done this, right? Skin. CTC, familiar with that? With that, yes, CTC, color, temperature, condition. 3 things we look at. Now do you understand, when I described the skin in shock, I said cool, pale, and diaphoretic, or cool, pale, and clammy? You understand what we were doing there?
CTC.
CTC, right? Color, temperature, condition. Doesn't have to be in that order.
Was that Russian Tavis intentional?
CTC.
No, the order of the vital signs.
No. What does it say? Sperm. No.
Spermie.
Look at the burn.
It's short for spermie.
Seeing as you're paying attention.
Yeah. Okay.
What's condition?
Whatever works.
That's the condition was
Clammy.
Yeah. Wet, dry, clammy, stuff like that. Heart rate, right? Rhythm, quality. We're gonna practice this stuff. Eyes. Pupils equal and reactive to light. Respirations, we have rate and quality. Lung sounds. Here, look at this. Mid-axillary, mid-clavicular. Right, we spoke about these points. Mid-axillary, that's where we're going to take our lung sounds. Mid-clavicular. Okay. Mental status, AVPU. We've spoken about this. This is something really important. AVPU. AVPU, AVPU, AVPU on every patient. Okay, we'll teach you more about exactly how to do it. And of course, blood pressure, systolic and diastolic. Sample, have I ever mentioned this? In the earlier, right, let's just run through this again. Sample is an acronym to remind you the questions you need to ask every single patient. Every patient. You need to ask the sample question. Doesn't matter if they stubbed their toe, if they broke a nail, doesn't matter. Or if they're about to die. You need to ask them sample, if you can. Alright? So, signs and symptoms. What's going on? Why'd you call us? Where do you feel pain? Do you feel pain anywhere else? What else is bothering you? All that falls into the signs and symptoms, and it's really, really important. I had a patient this morning who was complaining of back pain. Back pain, back and butt pain. Okay, fine. But then I asked her, anywhere else bothering you? Any pain in your chest? Yes. My chest hurts. Oh yeah, where? Boom. Heart, substernal. Okay, good. So if I hadn't asked, because that pain was moderate compared to the pain in the back. All right, we call that a distracting injury. That pain was so severe that she wasn't even focused on the other pains or things that are going on in the body. Allergies. You need to ask every patient this about 6 times in 10 minutes because, I don't know, they lie, they forget. I'm not joking, okay? And they make you look like a fool when you get to the hospital because you'll be presenting to a doctor or to a nurse. Yeah, no allergies, they don't take any medications, and they'll be like, yeah, as it happens, yeah, I forgot to tell you, I'm taking da-da-da-da-da-da-da. Like, really? I spent 20 minutes with you, and you didn't mention that. I asked you 8 times if you were allergic to anything or you take any medications. The best one was once I asked the patient, so you ever had any surgeries? No surgeries. I took off his shirt to listen to lungs, check him out. He's got a great big scar right down the middle. The only surgery typically that, has that scar is a coronary artery bypass graft or a, what do you call it? Cabbage, we call it in medicine. I don't know how you say it. No, there's a way to say that. Like lay people say they had a open heart surgery, stuff like that, right? Bypass.
He was sleeping.
No, so he's telling me, oh, but that was 20 years ago. I didn't think that mattered. Yeah, right. So that's a huge part of their history, okay? So, people are strange, right? We have to deal with this. We deal with this all the time. Okay, they either lie, or they think it's gonna shot the shidduch, or they don't want to tell you, or they forget. There's so many reasons why you don't get the straight answer. But the best one is when you wheel them in, and then they tell the nurse stuff that they never told you. Ask these questions, and you look like a real moron. Because the nurse is looking at you. Doesn't it say on your chart, no meds, no allergies, no history? All of a sudden, right? They've seen every doctor in New York. It's great. I love it.
I saw
Anyway.
online last night, this girl was writing, her boyfriend's a 911 operator. So she writes, my favorite is how meandering people are, even in the midst of a terrible emergency. They respond to, what is the emergency with, well, the thing is, 4 weeks ago. What is the emergency right now? And they're like, so what happened this morning was, I said to my wife, I said, what is currently happening at this moment? Oh, I'm having a heart attack. And then my second favorite is how specific he has to get sometimes. Like, what is your emergency? I'm sitting in a pool of blood. Is it your blood? Yes, I think so. You know where it's coming from? Probably the stab wound. Have you been stabbed? Oh, yes.
Fantastic. But this is so true. We get stuff like this. We really do. We really do. That's fantastic. All right. Past medical history. Sometimes you get patients that do the opposite. When I was 4, and now they're 82, I had a hernia repaired, right? And whatever. So, yeah, a broken arm. Women will tell you about their pregnancies and all this good stuff. We don't care. Okay? That's not what we're looking for.
You okay with
We want to know about the bypass, the quadruple bypass. We want to know about that. We want to know if they had a thyroid, a cancer, something removed from their body. These are the sort of things we want to know. Major surgery, major diagnoses that they've been given, whether it's thyroid, whether it's breathing disorders and diseases, diabetes,
It mentions about
cholesterol,
hysterectomies
all
also.
this stuff.
Mention the book about hysterectomies, why is that very?
Something
No.
removed.
That's having something removed.
Because I mentioned like multiple
Anesthesia.
times about it. That's
Okay.
an important part of the sample.
Again, having something removed, I want to know, I want to document it. That's part of their medical history. Okay? Last thing they ate or drank. People don't understand the importance of this question, so let's bring it into real life. You take a patient, and for whatever reason, they go unresponsive on the trip to the hospital. It can happen. Now they need a surgery, for whatever reason. Surgeons and anesthesiologists don't like performing surgery if they don't know what is in the stomach. Typically, when it's an elective surgery, you can't eat for 12 hours before. Alright? 8 hours, they let you drink some water, whatever it is. They all have different, mishigassen. But they don't want you drinking and eating. So if you're able
Is there a
to
reason
talk,
for that?
yeah,
Which
it can. They don't want you to throw up in the middle of a surgery when you're unresponsive with a tube down your throat, or before they put the tube, or as they're putting in the tube. Okay, so if it's an emergency surgery, and they know that the person ate in the last 2-3 hours, then they can take steps to make sure that they're okay with that. All right? There are things that they can do. It's not the end of the world, but it's better if they know. Events prior to the episode, just think of what's going on in the patient's life. I use this to find out about stressors, whether it's family, work, other environments, anything that could be causing some of these symptoms. Very often, physical symptoms are caused by psychological stresses. So you shouldn't just rule it out and say, that's nothing. It may be very much involved. Want to pause?